Hello, and welcome to another of our digital slide sign-out sessions. Today we'll be talking about some unique ovarian tumors and hope that you will enjoy this conversation. Our program is part of the Digital Anatomic Pathology Academy, a joint venture of the Digital Pathology Association and Path Presenter. And we hope that this will become part of the residency in the cloud effort that we are engaging to produce. I always want to remind you that you can turn on subtitles on YouTube and get a nice transcript of my words if you don't understand my accent or can't read my lips in this situation. So the case today is that of a 25-year-old woman, maybe 26, who presented with some increasing abdominal girth and discomfort, and was found to have a rather bulky pelvic mass involving one ovary. She came fairly promptly to surgery, having obtained preoperative tumor markers, and those pretty much being negative. A rather bulky mass was submitted for frozen section evaluation, which you see here. At low magnification, you can see it's fairly cellular. We don't see normal structures. And as we hone in, we see there's some areas of more edematous changes and some quite cellular areas, somewhat geographical, with nesting and perhaps even some cords of cells. So just thinking about this process, what are we being asked to do at frozen section for a mass in a young woman? Well, primarily we need to help them to know what additional or further surgery they need to do as far as staging, lymph node sampling, and things of that sort, so that the better we can subclassify the tumor in terms of general categories and grade of tumor, the more helpful we can be, even if we may not be able to render a completely specific diagnosis. As we come into further high magnification here, we see there are some small nests and cords, maybe a few little trabecular structures in this tumor. It's quite cellular, and these are relatively small cells as we look at them here. So we might be thinking things like neuroendocrine tumors. We might be thinking things like sex cord stromal tumors. In this category, particularly in this age group. And so how are you going to word your diagnosis? Well, this looks like a highly cellular tumor, relatively high grade with some mitotic activity. So I think it would be pertinent to inform the surgeon that this is a fairly high grade cellular neoplasm, possibly sex cord stromal or other in its characterization. And that therefore they should stage it as though it could be a malignant neoplasm. That should give them enough additional information to sample the peritoneum to determine whether or not a hysterectomy needs to be performed and to provide further information with permanent sections. This is a very challenging frozen section, and I'd encourage you to study it to see how you might respond in this situation. I think it would be extraordinarily difficult, even now knowing what the diagnosis is after the fact. So the next day, of course, we get some permanent sections, and we see a fairly similar appearance, very blue neoplasm, sort of lobulated, intervening areas of necrosis, not a good sign, of course. And then this sort of almost organoid or trabecular or nested pattern, a lot of sclerosis in this tumor, a few larger spaces of uncertain significance, and some very cellular areas. So as we come into higher magnification, we see these sort of sheet-like growth in areas, a few more trabecular areas, and very small cells, quite blue, raising a very interesting differential. So I would begin to think about small blue cell tumors, for example, rhabdomyosarcoma, Ewing's, primitive neuroectodermal tumors, and so forth. as possible considerations. Certainly some of the sex cord stromal tumors can have very small cells. I'm not seeing any sort of dimorphic features here, but poorly differentiated Sertoli Leydig cell tumors might have some features like this as well. So let's just ask ourselves kind of what the differential would be of high-grade ovarian neoplasms in a young woman. Well, certainly germ cell tumors, just germinomas, yolk sac tumor, embryonal carcinoma can have a very high-grade appearance. Poorly differentiated Sertoli Leydig cell tumors or granulosa cell tumors can also be fairly small blue cells, high-grade appearing. Immature teratoma, if it's predominantly sort of a small cell differentiation sort of thing, certainly could have lots of small cell areas, but usually would have other heterologous elements mixed in and better differentiated areas. Small cell carcinomas, primary to the ovary, certainly can occur in this age group, particularly the hypercalcemic type. And then we start looking at more general small cell neoplasms like Ewing's, rhabdo, lymphoma, neuroblastoma, and so forth. In an older age group, we might think about undifferentiated carcinoma or dedifferentiated carcinomas having this possibility. Metastases, small cell melanoma, or somatic neoplasms coming out of a teratoma could potentially have this appearance as well. So it's a fairly broad differential, and further study certainly seems warranted. So we'll look at the rest of the sections that we've scanned in here just to give a little bit broader array of some of the morphologic findings. So again, we see a lot of blue cells, but notice up here, we're seeing some sort of small cystic spaces. Maybe you'd say they're sort of empty, a little bit follicular-like. Here you see some with sort of a few floating cells in the midst of this. So potentially some slightly follicle type structures with clear fluid. Some myxoid cells. We're not seeing much in the way of large cells, although there are a few areas here where, as you can see here, I think, that some of these cells are pretty good size, and here sort of have macronucleoli and getting a little bit more cytoplasm. There are some large cell variants of small cell carcinoma that can occur as well and have more abundant cytoplasm with these large, almost luteinized or decidualized type cells with rather abundant cytoplasm, along with the smaller undifferentiated appearance that we've seen in the other sections. So it's important to recognize this feature in the tumor as well, the presence of small follicle spaces and some larger cells. We'll look here at another section. This highlights the fact that this tumor had involved other areas of the peritoneum and the pelvis. Here, fallopian tube, and obviously our neoplasm here in several sort of cannonball-sized nodules involving the tube and adjacent structures. So this appearance, again, back to the more small cell appearance with very diffuse sheet-like pattern growth in the appearance here, with only occasional, maybe larger cells, but still very mitotically active. So as you've been looking at this, perhaps you've been wondering kind of what sort of an immunohistochemical panel might help us. And based on our differential, of course, we'd want to do cytokeratin, some sex cord stromal tumor markers, perhaps some neuroendocrine markers as a possibility, maybe some germ cell markers as well. Of course, there is one tumor on that list that also has a very useful molecular marker that is the epitope for the SMARCA4 epitope, that's BRG1. So we're going to do a number of stains in this situation just to see what we come up with. So here's a cytokeratin stain, which, as you can see, is kind of patchy. Some strong areas here and a little bit of more kind of weak background or maybe even dot-like staining in a few areas of this, but not, by far not all of the stains are staining positively. There is some nice, strong positive staining, but a lot of areas of virtually no staining. When we do neuroendocrine markers, we get a somewhat similar appearance with a little bit of patchy variable staining, some areas stronger, some areas totally negative. This might be due to an aberration in terms of, access of the stain to the sections. Certainly you want to be concerned about that kind of a quality issue where you see some evidence of sort of waving or non-specific staining here. But I think we could say that some of this is certainly specific positive staining for the marker. But we certainly have areas as well that are completely negative close by. And that would be maybe discounting us a little bit from a neuroendocrine carcinoma. And then with GATA3, again, we could see some variable staining, some areas positive, other areas negative. With our BRG1 stain, which is the SMARCA4 epitope, this tumor showed total loss of the epitope, which is very specific. There's really only two ovarian tumors that can have that. One is dedifferentiated or undifferentiated carcinoma, and the other is small cell carcinoma of hypercalcemic type. Of course, those two tumors have a somewhat different age range to be expected, and so we arrived at the diagnosis of small cell carcinoma of the ovary, hypercalcemic type. Now, I will admit that I was a bit jaded as I was learning pathology, and that I was studying in an institution where these kind of cases were referred for expert opinion from one of our mentors quite frequently, and he was in the process of writing these cases up and would share them with the residents quite regularly. And I began to believe that, this was a common tumor, because it certainly showed up in our unknown conferences with some frequency. However, I've since learned that it's relatively rare, really quite rare, less than 1% of ovarian tumors. And while hypercalcemia was a part of Dr. Scully's original description of these tumors, it's really been found that only about 2/3 of these have hypercalcemia evident. And in our patient, in this case, the calcium was not elevated. Now, many of these tumors can also contain areas of larger cells. There is so-called large cell variant, and some have other minor epithelial components which can confound the appearance as well, such as mucinous tumors, which you can also see with other with some sex cord stromal tumors and Sertoli tumors and so forth. There, you may also identify clear cells. We mentioned that it's a SMARCA4 deficient tumor, but it can be positive with some of the stromal markers like WT1. It's usually also positive with P53 and P16, but can be quite variable with these other markers, including the neuroendocrine marker, cytokeratin, and we would add to this GATA3. It's usually negative with inhibin and TTF1. Now, many people have made a big deal about the small cell carcinoma of the ovary of pulmonary type, which is not included in the most recent version of the WHO classification, but is certainly reported in the literature and in several areas has been contrasted with this lesion. That tumor resembles, in general, other small cell neuroendocrine tumors, may have the azoparty effect, et cetera, et cetera. And typically, the age group is quite different. This is an advanced age, postmenopausal usually, whereas hypercalcemic type is usually premenopausal, younger, median age of about 24. And immunohistochemically, these are somewhat distinct. There is a bit of overlap in terms of the neuroendocrine markers and so forth, and the TTF1 negativity. But the markers like BRG1, WT1, and so forth would be entirely negative in the pulmonary types. You also have to, of course, consider metastatic small cell carcinoma from the lung, and there can be considerable overlap here again, but those usually are TTF1 positive. and CK20 negative, whereas hypercalcemic and pulmonary types will probably be CK20 positive. And in terms of treatment and hypercalcemia and so forth, these are usually somewhat distinct in that regard. As we've mentioned, only 2/3 of the hypercalcemic types have hypercalcemia. And as indicated here, these are not very chemo-responsive at the present time. We're still looking for appropriate treatments, perhaps based on the SMARCA4 inactivation and loss. So that brings us to the conclusion of our discussion on this case. The final sign-out diagnosis is small cell carcinoma of the ovary, hypercalcemic type. We hope that that will be a useful case discussion for you the next time you encounter this challenging and really quite rare tumor on a frozen section or in a clinical section and situation. Of course, if the patients are young and have hypercalcemia, the diagnosis is much easier. But if they have mostly corded and nested pattern, as in our case here, they lack the hypercalcemia, you're going to usually need to go to the immunohistochemical staining to develop the diagnosis. Please give us a thumbs up if you like this video, and subscribe to the channel so that you can catch future releases as they come out. We're producing these with some consistency so that we can develop a library that will be of use to trainees throughout the world, as well as our own trainees in our program here at Oklahoma. And so until next time, thanks so much for joining me.